Hi, Namaskar. My name is Rajat, and I have with me a couple of guests, Dr. Raju Easwaran, he's a sports surgeon, and Dr. Darren Player. He's an exercise referral specialist. Now, the whole idea is when surgeries are needed in sports people, when there's no other way but the surgery is needed, how do people get back to life performing at the highest level after the surgery is done? So, what needs to be done then? So, we'll be talking about that, and we'll have a very surgical opinion, exercise referral specialist opinion from myself, a sports physician's opinion, like, how do we deal with stuff like that, okay? So, Dr. Raju, why don't you introduce yourself? Just explaining a little bit more about yourself, about your background.
Yes, so I'm an orthopedic surgeon, and most orthopedic surgeons you would associate orthopedics with mending broken bones, but we also take care of ligaments. And I have specialized into orthopedic sports medicine. So I mainly do minimally invasive surgeries, sometimes open surgeries, which involve athletes, their injured ligaments. And that's what I've been doing for the past decade or more.
Right, and a little bit about institutions like.
So I'm a Delhiite through and through. I've done my MBBS from Maulana Azad Medical College and then followed up with masters at Substitution Hospital. I then spent a little bit of time at All India Institute of Medical Sciences, further honing my skills, and then many places across the world, and finally crystallized back here in Delhi doing sports surgeries.
Brilliant. Darren, same.
Yeah, so I'm an academic at University College London in the Division of Surgery and Interventional Science in the Faculty of Medical Sciences. So my research interest is in muscle physiology,
Right.
and specifically how muscles adapt to exercise and also in response to particular orthopedic conditions. I also have a background in sport and exercise science and particularly personal training and exercise referral.
Right, and again, institution-wise, we were talking about LAPRA and your postdoc and your doctorate from there. Just tell us more about that.
Yeah, so I spent some time at Loughborough University in the UK, which is a premier sports science institution. Spent some time in the National Centre for Sport and Exercise Medicine before moving to UCL. One of the reasons that I'm in Delhi is I've got some research collaborations at the All India Institute of Medical Sciences and also at IIT Delhi.
Brilliant. Okay, excellent. Now let's just get right into it. Okay, so injuries happen. How many times, being the surgeon, sir, how many times, what percentage of sports people, when they complain about of a pain or an injury, let's talk about a knee or a shoulder, how often would a surgery be needed?
Not that often. So it's the end of the foot chain kind of a thing, surgery. Most of these injuries can be actually very well managed through appropriate exercises, sometimes a little bit of rest, alteration in the technique. So I would say in terms of percentages, hardly 10% might need a surgical intervention, but then it may vary from practice to practice. If you're in a referral practice, you may actually see a more percentage of surgical interventions being done, but then if you're in a primary care kind of a practice and you care for the entire spectrum, the percentages will be far lower.
Right. And again, similar numbers for you, what would you say?
Yeah, I expect so. I think of a similar opinion that surgery should always be the last port of call.
Right.
If there's other conservative therapies that are possible, that should always be addressed first. But ultimately, there are scenarios that will require some form of surgery.
And if a surgery is needed, again, I'm not a big fan of rushing into surgeries. So I'm not saying I don't want surgeries to be done, but if they're not needed, why do them? Why do them unnecessarily? If they are needed, then what should we be doing? So, you operate. Would you do a surgery right away, or would you ask for prehab? We were talking about prehab earlier.
Yes, so in most situations, you can wait. It's never a very good idea to operate an acutely injured joint. You should let the swelling settle down. You should let the patient understand what he or she is into, give them some time to cope with their injury. And there are situations where you need an emergent surgery, but they are far and few between. In most instances, a month, maybe a bit more, month and a half of prehab will actually augur well for the final recovery.
Any set durations should we be doing for prehab? Should it be a fixed 6 weeks, or again, should it be any fixed durations for it?
6 weeks seems to be the orthopedic unit of time, so we will probably stick by 6 weeks.
Right.
But yes, it's a tightrope walk. You have to find out certain criteria, like in a common injury, like an ACL injury. I would like to operate when I see a knee with minimal swelling, a knee which is fully straight, and a knee in which patient has good single leg stance. So that's when I know that the quadriceps are reasonable, and that's when the patient would actually get bang for their buck, especially if the patient is an athlete performing at elite levels.
Excellent.
Yeah, I think I agree with that. It should be very patient focused. just ascribing a particular time for an individual is probably not the best approach. Making sure that their function first and foremost is in the right place before they go to surgery, and hopefully that will then maximise their recovery after the procedure.
Brilliant. And would we say the same thing for a sports person versus someone who's not a sports person?
Well, I would probably not treat any of them differently. The person who is not a sports person may have gotten unlucky while getting, let's say, an ACL injury, or might have been doing a recreational sport and got an ACL injury. Everybody deserves to have a surgery which will serve them for a lifetime, and the best way to do that is to condition yourself properly and to know what you're getting into.
Super. And same thoughts, or?
Yeah, very, very similar thoughts. I think the most important thing before the surgery is to sort of make sure you've outlined what the goal is after the surgery, whether it be returning to elite level sport or whether it just be to return to normal daily life. And if that's your goal, then you should do everything you can within your power to maximise that recovery for that purpose.
Dr. Raju, just trying to be the devil's advocate, in the current scenario that we have in India and across the world as well, what percentage would you say that our surgeon friends are talking enough about prehab?
It's an alien concept to us surgeons. See, we are scalpel holding creatures, and we are a bit impatient sometimes at times, and we would like to see our patients get back to what they are doing very fast. Now, if you look at the traditional orthopedic surgery, trauma surgery, so there is obviously no practicality of doing a prehab, but when you are looking at soft tissue injuries, it makes ample sense, and there are enough papers out there, especially for an ACL. So if you're looking at a 20-year-old chap getting an ACL reconstruction.
I'll stop you just there, sorry. Soft tissue injury.
Yeah.
So just elaborate on that, because most people won't understand the difference between trauma and soft tissue injury.
And that exactly is the point. A lot of my patients, especially from the rural background, come and tell me that there is nothing wrong on the X-ray. Why do we need a surgery? So it is sometimes very hard to make them understand unless they are very unstable and they can't take a single step.
Right.
That's when they actually understand the gravity of a situation vis-a-vis a situation where they fractured themselves, for example. But you have to tell them, and I use animations a lot. So I show them animations, I show them what exactly they have injured and what they would land up into if they don't get themselves properly treated. So it is hard. I'm still learning on how best to teach our patients, especially from the rural background. The ones who are urban, elite, well-read, they would actually have more knowledge about the injury than what you do at times. Right. But it's the people who come from the rural backgrounds, and often a lot of our players come from the rural background, and they have very limited understanding of their bodies. So it's a constant learning process, and maybe I'll improve after this conversation with you.
For sure.
Just to pick up on a topic there, I think when it comes to prehab now, people are well versed in these areas. Everyone can access the scientific literature now.
Yeah.
So even if you are a lay member of the public, you can actually go into these surgeries with a good deal of knowledge as to, what's the type of surgery, how is it going to affect me post-surgery, what can I do beforehand to make sure that I'm in the best place. So I think more and more as we see the research coming out and the accessibility, people will be a lot more informed.
Brilliant.
So I will just point out one slight change in context. So here in India, people do a similar amount of online research, but with a slight difference. In India, people will probably look up, for example, if they are looking me up, they might go to my website, and in my website, like in any other surgeon's website, I proclaim to be the best orthopedic surgeon on planet Earth. So it's not a peer-reviewed information. So they would probably not go to places like PubMed. The other very popular source of information that Indian patients have is on Facebook. And a lot of colleagues post very detailed videos on Facebook, and sometimes even Facebook is not peer verified. So the one platform which is severely underutilized, I feel, at least in India, is Twitter, where you actually get good peer verified information, where you can't post anything without double checking it yourself. So I would actually encourage people to come on Twitter and to follow opinion leaders on Twitter.
Right. And Darren, again, just a little bit more about what is a soft tissue injury versus a traumatic. So just for the common man.
Sure. Yeah. So the soft tissue injuries, that's going to be addressing issues of the ligaments, the tendons, the meniscal tissue, potentially even the muscle tissue as well. So rather than the traumatic injury of the bone, it would be the other tissues.
So the fracture versus ligament tears and stuff.
Exactly.
Yeah. Okay. And
so to put it simply, if you have an orthopedic injury and if you have not broken a bone, you have a soft tissue injury.
Yeah. That's what it is. And if people get surprised, but X-ray is normal.
Yes.
So X-rays only show bones effectively, right? And gold standard, while we are at it, so gold standard would be what for us, like investigation-wise, what has
The best gold standard in my hands is a simple clinical examination.
Brilliant. Yes.
But sadly, most people come to me with an MRI in their hand. So I generally don't order an acute MRI. It doesn't add to my information and generally doesn't show things in accurate detail.
Right.
But a simple clinical examination would at least help me identify, oh my God, kind of problems.
Yeah.
And sometimes I do get an MRI done.
Right. Right. Ultrasounds, CT scans.
Ultrasounds have a problem in Delhi. So when I was when I was observing people in London and other parts of UK, for example, the shoulder unit used to have an attached ultrasound room right next to it. So here,
right.
due to some legal issues, we don't have that free access to ultrasound. And the same problem has led to a very few number of people doing good musculoskeletal ultrasound in Delhi. I mean, it comes as a shock to
Unfortunately,
most,
yes.
but then you can count the number of good musculoskeletal ultrasoundologists on your fingers.
Right.
There are not more than 10 of them.
Right. And role of CT scans. in such
CT
injuries?
scans in soft tissue injuries have a very minuscule role. They do have a role in help us planning out, let's say, a shoulder stabilization, where I'm interested to study the amount of bone loss happening in the shoulder, but that's a very technical thing. It's probably not meant for the lay audience.
Mhm.
So I would probably say the main investigation is an X-ray to rule out a bone injury, and if your doctor feels so, maybe an MRI.
Again, sometimes, and open to both of you really, but arthroscopic, sometimes it's diagnostic rather than therapeutic as well. Just again for the lay audience, saying what is the role of that?
In
all
the
of this?
present day and age, diagnostic arthroscopy has no role.
Excellent.
If
Yeah.
I have to operate a patient, I need to know the diagnosis, period.
Brilliant. Before you go in.
Before
right?
I go.
Awesome. Any thoughts on that, Darren?
No, I think just to go back to what are the functional limitations.
Mm.
So from that initial exam, if you can actually outline what the functional limitations are of the joint, so not necessarily just solely the particular injured site, but how that affects the complete limb movement, that's probably the most important thing for me.
I see a lot of back and knees. Knees still, it's very fascinating that people do, when I say people, I'm talking about doctors, examine the knee. Back, you'll be surprised without seeing, and they pick up the pen and things are being written.
Yeah.
And it's like, how does that even happen? And the MRI obviously, and that's the sad state, right? Most of the times, patients get it with them without any prescription whatsoever from our colleagues, because it's easily accessible. Anyways, just getting on with the surgery part. So surgery is done because they needed it, and that was the only way. How important do you think is the post-op then?
I always tell my patients, your recovery, if I can put it as a percentage, 100%, probably 40 to 50% will be because of what I do, and the remaining 50% will be how well you exercise and how well you're guided by your rehab expert.
Brilliant. That's rare, I think. How many of our colleagues would say that?
I say it for a different reason as well. So if the
Right.
recovery doesn't go according to the expectations,
Yes,
I can
therefore.
at least blame the 50% partner. But then that's on a lighter note, but it's equally important, especially for an elite performing athlete.
Right.
Any athlete who has returned back after orthopedic surgery has probably returned back more because of his efforts with the exercise than with what the surgeons did.
No, but just to take your point that you made earlier also, you're putting the onus on them as well.
Yeah.
It's proactive role rather than
They
saying
need to
passively you need
understand.
to fix it.
Yes, they need to have realistic expectations. They need to understand, more importantly, the time frame. The coach will be always pushing them to get back into the sport as quickly as they possibly can. But there are some standard timelines for every injury. Like for ACLs, it is now more or less agreed that the minimum time for return to sport should be 1 year, and that too after passing certain criteria, RTS criteria. So they exist for other injuries as well. So they should have realistic expectations. This is, after all, elective surgery. You can't rush any athlete or any person into a emergency soft tissue surgery unless you're dealing with a knee dislocation, for example. I mean, that's a rare instance.
Right. Yeah.
I think even just for the lay population, just getting back to any level of physical activity after surgery, that initial period is absolutely fundamental in getting the right behaviours in place. So, if you're not addressing the immediate rehab need, then what's going to be the long-term impact of not doing that? So, making sure that you're doing the right exercises long-term, not just in that initial period, that's one of the most important things.
We moved from a term mnemonic called RICE to price to police. Would you want to kind of take us through that? Where did RICE come from? What did it mean?
Okay.
Where are we now? Optimal loading today. What are we
Sure.
talking about?
So in terms of RICE, so rest, ice, compression, elevation,
Yeah.
that was the initial thoughts. which obviously do have some utility in terms of acute inflammation, preventing any further damage of the tissues, that kind of thing. But then moving forward with movement, ice compression, elevation, getting more active. So how can actually making the joint more active contribute to, again, reducing the inflammation, but also protecting some of the other tissues, particularly the muscle tissue. And I think that's obviously where my expertise lies, is making sure that we minimise the amount of muscle tissue that's lost, and we maximise the functional recovery post-intervention. So obviously with just complete rest, so whether that be bed rest or whether that be on crutches or a sling or something like that, that's obviously completely unloading the joint. That's going to be affecting the muscle tissue. That's going to be reducing in terms of its size and function. So try to minimise the amount of time that we're in that particular situation is going to help in terms of the recovery.
Right. What about
one area where we have had a dramatic change in thinking, one injury, is a shoulder dislocation.
right?
So when I started my residency, an anterior shoulder dislocation would mean 6 weeks of rest in a sling, mandatorily. It used to be an arm chest bandage at that point in time, and in the tropical heat of Delhi, I sometimes used to wonder how our patients used to endure all this kind of a treatment. So now it's just maybe 4 to 5 days or at least a week in a simple sling. The moment the pain and swelling goes down, I would at least encourage my patients to exercise, to avoid, of course, the risky movements, but to start exercising. There are only 1 or 2 movements which can precipitate a redislocation. So yes, in a similar vein, to match the current fast pace of life, we need to alter our thinking and to decrease the amount of rest to the least amount of time we possibly can.
This could be confusing the audience. So what we're saying here is they need to go back to being active as soon as possible.
Under medical supervision,
Yes.
not giving themselves full bed rest, maybe a day or 2.
Yeah.
And then after that, you check with your doctor, you check what are the do's and more importantly, what are the don'ts.
Yeah.
And you'd be surprised as to how much liberty we can give you.
Yeah. So from going to activity very, very soon.
Yeah.
But at the same time, we're saying performing at the highest level, that elite, these leagues and all that happen. You're almost talking about a year or so with a knee, for example.
Yes. I tell all my people who have elite expectations, you have to miss 1 season.
Right.
If you are not ready to miss 1 season, I would probably be reticent to operate upon you.
Right. As much as that.
Because the failure of an elite athlete to return back to sport reflects a little bit on him, but it reflects badly on me as well. So I would probably be very stringent in that criteria that you need to miss 1 season. So I would never operate them when they are in season.
Right.
Only when they are out of season, when they have less important tournaments which they can sacrifice, that's when they should get themselves operated.
Right.
Wow. To be honest, I didn't realise the recommendation was that long. So in terms of then, the basic recovery, just to get back to normal walking, maybe light running, not the elite level of performance, but just getting back to sort of usual activities to keep the degree of conditioning that an elite athlete would need. How long is that period of rest?
That's less than a month's time. So that follows a standard protocol.
Sure.
But then for a reconstruction, you need, these are surgeries, these are reconstructive surgeries. If I just done a simple meniscectomy, you can go back to play in a month's time or so. But then these are special circumstances where you have reconstructed. And you need to let the reconstructed tissue, and the commonest surgery that most sports people undergo is an ACL reconstruction. So you need to miss a season, especially if you are in a sport which involves a rapid change of direction like rugby, football, cricket, basketball, anything of that sort.
And again, I think we need to agree and appreciate that we all are learning and changing our thoughts as well on a very regular basis. Because I used to be the one who would say aggressively work with an ACL rehab and get them back ASAP. Today, no, I don't do that at all. Some is evidence, some is experience as well.
And I'll tell you what, if you look at the Finnish registry, the Finnish ACL registry, we have changed our technique of doing ACL reconstruction. So previously, when I started my residency, we used to place the ACL graft in a non-anatomic way. So aggressive rehab could have been done with that kind of a graft because that graft didn't experience that much of load. So as we have improved in our surgical techniques, we are doing a more anatomical ACL reconstruction. So that graft experiences more load.
Right.
It needs a little bit of rest. And that is why major Scandinavian registries show a slightly higher chance of graft ruptures if a proper duration of rest and conditioning is not given to an ACL graft.
And talking to the patient, understanding where are they coming from. So we were talking about earlier backgrounds, cultures, someone being a Muslim or a Hindu, the point being someone kneeling versus someone sitting cross-legged, and talk about a knee injury. How relevant does that become to understand your patient?
I think that's absolutely fundamental. I think that's where the clinicians need to be working with the patient at that very first initial consultation to understand what are the requirements for that patient. Ultimately, what do they want to be getting back to?
Mhm.
Whether that is just kneeling, sitting cross-legged, or whether that's playing in Premier League football in the UK, understanding exactly what the goals are for that individual is extremely important.
Just elaborate on that, please. You know, we would, as
My
kneeling
incision
and
would
cross-legged.
change, my surgical technique would change.
Right.
You mentioned a Muslim patient, so if I operate upon a Muslim patient, they need to do their namaz 5 times a day.
Yeah.
I would probably choose a hamstring graft for their ACL, or I would probably choose a quadriceps graft for their ACL, but I will probably avoid giving an incision in the middle, in the front of the knee, because that may interfere with their kneeling and it'll cause kneeling pain.
Right.
So horses for courses, really.
Yeah. And that'll change our rehab as well, right?
Yes, it does.
Mm.
And you'd be better placed to point that out, because kneeling is something which is so part of day-to-day life activities of all Asians.
Yes.
So, let alone Muslims, we Hindus like to sit cross-legged. So,
Yeah.
we need to be able to do that after a reconstructive surgery.
Yeah.
We may not have elite sport anticipations.
No, but that takes us back to our very basics. Whether exercise or as humans, squatting. Our rehab needs to become very functional as well, rather than just saying, "Hey, listen, do the knee extension."
Yeah.
That is not enough, right? I mean,
No.
so the importance of functionality.
Yeah, of course. I think certainly the point of surgery gives you an opportunity to actually go back to the very basics. So understand what are those fundamental movements that we do on a daily basis which actually help lead our normal life. So whether that be squatting, lunging, particularly as well bilateral movements. So not just squatting with both legs,
Yeah.
squatting with a single leg.
Yeah.
You know, getting in and out of a car, that's obviously important. Just a very basic physical activity that we do, and understanding what are the movements which contribute towards that, and building that into the rehab.
My favorite line on that is, you know, we are not kangaroos. We walk with one leg at a time. And if you
Yeah.
can't do things with one first, you know, like you're not getting anywhere. And it could be a great surgery, but the point is, functionally, you're not going anywhere with your walking.
Exactly.
What do you think about that?
My thoughts, Dr. Rajat, is that we, in our basic orthopedic training, need to be even taught by professors in physiotherapy.
Yeah.
Because I remember my life as a resident, all I used to write on my ACL reconstructed prescriptions was quadriceps exercises, quadriceps. Every visit, quadriceps. It was almost like a life sentence of quadriceps exercises to the patient. So I, as a resident, didn't know any other exercise for the ACL injured knee. So we need to educate ourselves. We need to go to verified sources of information, and if we can have some simple guidelines, mainly championed by people like you, that what is the load on the ACL at a certain functional activity, so that we surgeons can get a broad understanding.
So that paper that just came out, and you know, it was on Twitter, and we were commenting
Yeah.
on it about meniscectomies and being done, and how much strength is there in the quads.
Yes.
Isn't there a bit of an issue with that? As in, again, it's very
It's
too
myopic.
simplistic. Very
It's a
myopic.
bit myopic to focus only on the quads, but it's not bad. I mean, you can, of course, exercise the quads, and the only way to do a good quads exercise is to squat, and that'll probably work the other muscles of the body as well.
Yeah.
So, in a way, it's good that some literature is emerging in the right direction, and more emphasis is being given to exercise. If you've had a meniscectomy, you are going to have accelerated degenerative changes in the knee. The only way to cushion that is to build a strong thigh, to probably build a strong back as well. Maybe I'll get more insights from you now in this regard.
So we were talking about the kinetic chain. So
Yeah.
taking on from there.
Exactly. So I think just isolating a single muscle isn't the full story.
Yeah.
You know, when we're walking, when we're squatting, it's obviously a multi-muscle, multi-joint movement. So doing functional rehab that's going to address that, not only is going to obviously improve the function of the quads, but it's going to help us with our everyday life. So, you know, making sure that we are activating the glutes, we're activating the hamstrings, making sure we are getting stability when we're activating the hamstrings. Those types of things, again, need to be addressed a lot more, and probably need a lot more scientific research as well.
Calves in the back and the whole lot, right?
Yeah, exactly.
Yeah.
It's not just going to be a single muscle that's going to be affecting the joint. It's going to be absolutely everything within that full chain.
A patient had written in with a question saying, had an ACL surgery, was a runner before, and then had been doing some sort of rehab, primarily focused on the quads, and then had inguinal hernias as well. Didn't bother doing anything for the calf, didn't do anything about the quads, and yet has pain after a year and a half.
Yeah.
What do you think is the problem there?
I think it's probably not doing multi-joint movements.
Mm-hmm.
So doing isolation exercises, obviously in the early stages, is very important. but then getting back to that multi-joint movement, doing a squat, a loaded squat where possible, doing full lunges and things like that. Obviously that's going to be activating the core, the lower back, all of the muscles in the leg, to give you that stabilization and movement. That's certainly going to help when you're looking at individual muscles. When it comes to the calves, obviously there's particular movements that you can do to isolate that, but then it's building that core strength in an isolated movement and then applying that into something a lot more functional.
Dr. Raju?
So my take on that, and I tell this to even non-ACL injured patients who, let's say, want to start a workout. They want to have a gym plan. So I tell them, which kind of interest do you think gives you more money, simple interest or compound interest? So if you do compound exercises, activities which move multiple joints like a bench press or a squat or a deadlift, you are likely to gain much more muscle mass than I see most people at the gym just doing biceps curls and hoping to build Arnold type arms. So my take on this is to focus on the entire body and probably be guided by people like you on what safe functional exercises can you perform.
Right. About squats, now what's been happening is with our colleagues, when there's a knee pain, and why only blame the colleagues, even the patients, because they have a knee pain, the area they won't exercise is actually in the knee. So it's sometimes the reverse as well. And sometimes the orthos or the sports guys or the physios also tell you not to exercise the knee. And then they specifically mention not to do squats, that squats is bad for you. A very, very high percentage are saying that. What are your thoughts, Darren, on that?
Well, I don't think we can avoid squats in our everyday life. So if you're told not to squat, as soon as you leave the hospital, it's probably one of the first things that you're going to do.
Yeah, when you sit and get up, right?
Exactly.
Yeah.
We probably squat multiple times a day, whether it be to get in and out of a chair or what have you. So yeah, I think we can't avoid it. So just doing the squat properly in the most appropriate way has to be addressed. So learning that movement pattern, what specific muscles to activate when, that needs to probably be addressed more.
Dr. Raju, squats.
It's the single most useful exercise. It's the single most misinformed exercise.
Yes.
Yeah.
Nearly all my patients tell me, especially if they have seen other colleagues, that squatting is bad for their knees, and I just tell them nothing could be further away from the truth. People who want to strength train also, they don't want to squat because arms you can display in public, legs you can't display in civil society. Yeah. But then if you follow the work of Sergio Oliveira, a famous bodybuilder, he said if you want bigger arms, squat.
I was just going to say that, yes.
Because squatting and deadlifting are the only two exercises which will secrete growth hormone, and in males testosterone, and that's the hormones which will give you muscle mass. So squatting is important, and particularly important in the context of knee surgery.
But even for a back and a shoulder and a upper back and a cervical, all of it, right?
Yes.
Squats again.
So it's one exercise which will work all the muscles from your little toe to your skull.
Yeah.
So it's one of the most useful exercises. If you have time to do only one exercise at the gym, it should be squats.
Brilliant. And it can be done without the gym.
And without the gym as well. Body weight squats, pick a heavy book and squat. You can do it in multiple variants. Lunge.
Yeah.
So it is a very important strength training activity.
Super.
Breaking down the squat though to the individual components and how the muscles are activated in those different segments, that needs to be taught a lot more so that the patient actually can feel the activation in the right area. Most people when they squat aren't activating their glutes enough. It's putting a lot more force through their quads.
Yes.
So making sure they know when they're going into that squat movement where they're initiating the muscle in the right place.
Excellent. Just moving to, we've spoken a lot about physical, and let's talk about other things that happen. The communication, we do this whole history-taking classes that we have as doctors and all that, and then we forget that because no one's marking us enough on that. And as communicators, we doctors are pretty pathetic actually across the board. Sometimes don't we cause the injury to get worse because of that?
Yes, it is very important, and you mentioned history-taking. And if you recall the teaching that is there in Hutchinson and all other clinical examination books is to speak to the patient in his or her own language, which in a place like Delhi would mean Hindi. And it is very important to speak to our patients in Hindi. It might mean other languages as well. Sometimes having the ability to speak in Tamil gives me a slight edge in that direction. But yeah, so all I'm saying is that you should be able to speak to the patient. You should be able to get down to his or her level and to be able to communicate information easily with a minimum of technical jargon, preferably in their own language.
Right. Yeah, and as a non-clinician as well, and having had ACL reconstructive surgery, I think for me it was communicating with the surgeon what was right for me. So what did I need from this
Right.
to then help me get back to my life? So sitting down and spending some time with the surgeon and discussing those things, was really necessary for me.
But most of the times what happens is, because of your background, you did that. But most of the times when the patients are coming, fair enough, they're demanding at times. But at times, they can be the other way around as well. They're looking up to that demigod across the table.
Yeah.
And they're too shy to ask any questions. And they're depending too much on us. And most of the times, forget about not a good history taking or misleading them as well, unknowingly. Or saying the wrong terms. I mean, I just posted something about, oh, you have a disc bulge, and if you don't do something today, you'll have a paralysis in some time. Forget the paralysis. The chap for last 2 years has been living a mess of a life.
Yeah.
Because they've been told what the
Yes.
future holds, when it's not necessarily true.
Yeah.
And so it's communicated in the wrong way. The worst case scenarios are projected, and not about 99% what happens to it.
Yeah.
So how do we change that? Where do we go with that?
We need to be realistic with each other. The patients need to be realistic about their expectations from an orthopedic consultation. We need to be realistic, and we need to be having some skills in psychology perhaps to be able to read the other person's mind and to understand what he or she wants. That's the basic tenet to any success in any surgery, especially when you're operating upon elite athletes. If you don't understand their mind, sometimes they are very insecure. They are insecure that they might not be selected for the team the next time. They'll be insecure that the club will not pick them up for a premier football game if they have undergone a knee ligament surgery. So you need to address those concerns, and you need to properly tell them. They might have seen other colleagues who may have told them that they'll take a year to recover. If you go and tell them that, no, I'll make you recover in 6 months, that's probably doing injustice to them. You need to be honest with them, transparent with them.
I think your approach, Dr. Raju, as well, by saying, look, 50% of the rehab is your responsibility. That's empowering the patient. It's giving them that responsibility to say, look, I have to do something myself here, otherwise this isn't going to work.
I think that's such a major shift in the mindset. It's
Yeah.
from very passive to saying, listen, I have a role too, proactively involved in it.
Yeah.
And we have such good online resources. So I use one such resource very often, scadefree.no, or the Get Set app. It's a very good injury prevention app, and I think the Scandinavians have done a marvelous job by making this content free, at least in India. So Go for Life, a lot of other very good websites. Twitter is a very good resource, and maybe at the end of this video, if we can give all our Twitter handles, people will do well by just following what we tweet.
Yeah.
So if you are careful, if you know where to look, you'll get credible information online, and then you'll probably know what to do.
One major one to avoid is WhatsApp, I think. Major
Yes.
one, even bigger than our Facebook.
Yes. I think Twitter is a very underutilized platform.
Yeah.
Mainly because you can't, most people can't express themselves in 140 characters. You can't say a lot of nonsense as well in 140 characters.
I think 280 now.
280
now? Yeah. So again, going into psychology a little bit more. So what happens is, again, there's pain, and because it's only this much, but because they're thinking about it day in and day out, and that whole catastrophization of pain is actually happening. So from this much, they've created such a big issue. And what role do we guys have in that? So fair enough, as a surgeon, the surgery is done, as exercise we've given, but yet the communication is very important for that. So where do we come in for that?
So certainly in the rehab, when you're prescribing a particular exercise, is making the patient aware that that's going to help them with their pain symptoms. So not only in terms of the function, but it's also going to give them, an effect with their pain. And then it's monitoring that process as well. Does a particular exercise cause them even more pain, or is it just acute pain, or is it long-term pain? And it's kind of understanding of all those things.
I think communication here again is the key. So I tell all my patients that elective orthopedic surgery isn't the most pleasant experience on earth. You are going to have a little bit of pain, and that pain might last you for a couple of weeks to 4 weeks or a month, or sometimes even more. And I tell them it's a subjective thing. What is painful to me may not be painful to you, and vice versa. So there are pharmaceutical approaches to pain. You can give them pain pills, but then in the long run, exercise is the best analgesic. It releases the same endorphins which all of these pain relief medicines do.
It changes pain threshold too.
It changes pain threshold too. Yes. So communication, a little bit of help through medicines.
And a realistic picture.
Yes, and as frivolous as it may sound, I ask my patients to meditate. It sometimes helps with their pain, especially athletes.
Brilliant.
Yeah.
And do you, both of you, breathing exercises? Do you prescribe or suggest that at all to the patients?
So meditation, I thought, was mainly about breathing. I find that personally very hard to do because it's very distracting for me. But then there are people who can, especially shooters, they can control their heartbeat very nicely by deep breathing exercises because they shoot in between heartbeats. Professional shooters. So that's something which I've picked from them. And yes, it's very good to do to control pain levels and stress levels.
I find it interesting. I mention it separately. So I would actually separately mention meditation. I would separately mention actually the breathing part. What I try to do with my patients is make it as basic as it can be. I don't assume that are they getting all of it. Can I make it really dumb it down as much as I can? And I find it very useful. So I would say meditation. I would say breathing separately to them.
Yeah, I think certainly with breathing, people often, they can see the physical benefits of that a lot faster by controlling their breathing, activating their core, controlling their core more efficiently, where meditation, sometimes it might take a lot longer for them to see the effect. So I think that's why it's probably important to keep it separate.
Yeah.
But clearly there's benefits across the board.
Yeah. Going to the topic that we haven't touched, nutrition. And prehab, post-hab, and in this world today where people are treating especially nutrition like religion, people are taking sides and they're not saying, we need to balance it well. It's always about this is wrong and that is right. What are your thoughts on that?
So nutrition is absolutely paramount when it comes to recovering from the surgery, but also getting yourself in the right place before surgery. So making sure that you are consuming enough protein to maintain your muscle mass. I think if there's been a period of bed rest, you may have lost your appetite slightly. Just making sure that you can get your appetite back as quickly as possible. Eating a balanced diet of all the macronutrients, getting different sources of carbohydrates, protein and fat, but also not undervaluing the micronutrients. So making sure that you are eating all of the different vegetables, the so-called rainbow diet, of getting all those different micronutrients in place. That's going to help regenerate those tissues a lot faster.
Roger, with
A
all your strength
lot of
training?
my patients ask me about supplements. Now, supplements before surgery, after surgery, general supplements if you are going to the gym. So all I tell them that if you are a non-vegetarian and if you consume non-vegetarian meals 3 to 4 times a week, you probably don't need additional protein in the form of supplements unless you are into heavy strength training. I generally prescribe them a rough formula of 1.5 times their body weight, the amount of protein requirement per day, 1.5 grams times their body weight. Thankfully, the elite athletes have people to manage their nutrition, and we orthopedic surgeons don't need to delve too deeply into them, and they're quite great experts in doing that. So I just follow Darren's recommendations: a good protein diet and a rainbow diet eating. And the one thing which I ask them to stay away from is processed food and sugars.
Yeah.
Right.
Especially when they are not exercising as much after surgery, they will rapidly balloon if they take all that.
Right. Since it's about Indian context here, and primarily quite a few, high percentage are vegetarians. And this whole protein bit is there.
Yeah.
And on again Twitter, for example, we have these sites that are there that vegetarians isn't good enough and non-vegetarian. We have a practical issue, right? Most are vegetarians. Now, how do we deal with that? What do we do for that enough protein intake?
I think it's just making people aware of what the specific protein sources are. So just saying, look, you can eat these lentils, you can eat these beans. This will offer you this much protein. Make sure you're getting enough in terms of the per gram recommendation. And then eating a variety so that you're getting all the different range of the amino acids. So you're not just eating one form of lentil or a different type of bean. You're eating different sources of protein throughout the week, so you're getting that full amino acid profile.
Simple diet substitutions.
You're a vegetarian.
I'm a pure vegetarian. Even though I look like a carnivore, but I'm a pure vegetarian.
No, but I wanted it for the patients.
Yeah.
How do you take care of your protein?
So, simple diet substitution. So, I consult an expert dietitian. So, I'm an orthopedic surgeon. I'm not an expert in nutrition, but I can just give you the broad gist of the advice that she has given me. Substitute tofu for paneer. Paneer is a very commonly consumed vegetarian food item. Take lots of dals, lentils, as you mentioned. Quinoa. There are a lot of good protein sources in vegetarian diet available. You can always take whey protein, sprouts. In fact, I lost my weight primarily by just eating sprouts. So I just ate sprouts as one major meal through the day. The breakfast and the dinner were standard, and just ate sprouts for nearly a year, and it helped me shed weight. Of course, in combination with exercise. So I think for diet, you should probably consult good online sources. Again, Twitter, there are very good online plant diet sources available on Twitter. The simplest is, of course, to go to a good sports nutritionist, and he or she would be able to help you out.
Brilliant. Last bit about nutrition. Carbohydrates, how bad are they?
I think the important thing here is the context.
Yeah.
So if it's highly processed carbohydrates, when you're not concerning yourself with any exercise or anything like that, clearly that should be avoided. But positioned in the right place, they certainly have a place. Whether it's for sports performance, whether it's for daily life, as long as they're being placed in the right area,
There is
and
a
the
need.
right source of carbohydrate, there isn't an absolute need.
Brilliant.
I'm not an expert to answer that question, so I'll probably just nod my head in the right direction.
Yeah, no, so just for recovery, so prehab, post-hab, when we say recovery, which will play a slightly more important role? If we are saying balanced diet, but yet to focus a bit more on what?
So in terms of the sources of the foods, you mean?
Yeah.
So I think particularly with prehab and rehab, is that when you're getting the carbohydrate sources in, that should be in and around when you're actually performing the exercise.
All right.
That will mean that your body is taking up that glucose into the cell, so the carbohydrate source becomes glucose inside the cell, independent of the requirement for insulin. So that will certainly help your body utilize that glucose a lot more effectively. So if you are going to consume carbohydrate, make sure you're doing it around about when you're exercising. But that should be the general recommendation.
Protein?
And protein, similarly, protein should be consumed throughout the day. So protein intake, particularly amino acid intake, obviously that's digested from the protein, will stimulate protein synthesis within the muscle to maintain muscle mass. That can also be extended by exercising. So just by exercising alone, you can stimulate protein synthesis. But obviously consuming dietary protein around that time will also help increase that protein synthesis.
And fat again, I'm sorry, but fat again, because very, very important. There's a lot of misinformation out there.
Yeah, there is. And again, I think it's the type of fat, the source of fat, whether it's coming from highly processed food. Obviously, fat is extremely important for the diet, for the synthesis of certain hormones. So not completely avoiding fat, using natural sources of derived fat. That's going to certainly put you in a better place than taking all these highly processed fats.
Brilliant. Now, just in closing, the whole intent of this session that we're doing is, when the surgery is needed, if that's the only thing that can get you out of the problem that you're in, how to recover, how to get back to your best.
Yeah.
In closing, what would you say?
I would say just the importance of exercising as early as possible. So getting that as part of your prehab, and then doing it as soon as possible in your rehab, and then maintaining those behaviours throughout the rest of your life.
Brilliant. So it's not only limited to, hey, listen, for a year or 6 months.
Absolutely not.
Excellent. Good point. Dr. Raju.
I would say have realistic expectations. Do a thorough research on your injury. These days, good information is available online. Have realistic expectations. Exercise before and after the surgery, and make it a lifelong habit. And with the right combination of luck, the right surgical technique, and mainly exercise, you will get back to what you're doing.
Brilliant. Thank you, guys. So we were talking to two experts from very different backgrounds, but about the best recovery that people can have after surgery. We will come out with such videos, so whatever those things are, like, subscribe, all that stuff. Do that, and we'll be back soon again with the next video. All right. Thank you. Thank you, guys.